Okay, so the caveat in evaluating mild mitral valve stenosis is that we have to make sure the left end diastolic pressure in the left ventricle is not elevated and falsely giving us a lower number, because if we have significant aortic stenosis, coarctation, aortic regurg, subaortic stenosis, then the pressure here during diastole will be higher, and hence the gradient will be lower, and yet the left atrial pressure will actually remain high. It's just that we are falsely measuring because we are only calculating, minusing left atrial from EDP and getting a number. So numbers don't mean much when there is associations with other lesions. When there is association, your pathophysiology may be quite different, and we'll have to figure out which is the most important lesion, and that most important lesion will give you the most important significant pathophysiology. So if we just finish talking about mild mitral valve stenosis, let's talk about moderate. What is the mean gradient where we call it moderate? The mean gradient would be anything between 7 to around 12, or maybe just 10, let's say 7 to 12 millimeter mercury mean gradient. That is a difference between the left atrium and the end diastolic left ventricular pressure. Now the mitral is more stenotic, as you could see. If we said that the left atrial pressure was 8 in a normal person plus 12, then now the pressure in the left atrium is 20 millimeter mercury, and obviously in the veins it will also be another 20, and in the pulmonary artery, if now the difference, let's say, is 12, and we know that we had a mean PA pressure normal between 10 to 18, add that 12 to the 18, we said it was about 25 to 27 in the mild. Now we will have a PA pressure of around 30 mean millimeter mercury. If we add the 20 millimeter mercury to give the systolic, or 25, whatever you choose, it will be around 50 to 60 millimeter mercury. So we would expect now at least moderate elevation of the right ventricular systolic pressure, anything between 45 to 60 millimeter mercury. 45 to 60 millimeter mercury. And here we do have moderate elevation of the right ventricular systolic pressure. If we know that, then we can actually figure out the pathophysiological effect. Let's start from the mitral, and just after it, would that affect the cardiac output, moderate mitral valve stenosis? No, the cardiac output will be maintained. Would that affect the EDP? No, but it could be on the lower normal. Would that affect the cavity size? Possibly. Mild decrease in left ventricular end diastolic volume, but not significant, and that would be it. Would it cause any effect on the other after structures, like on the aortic valve or the aortic arch? Usually not. It's only moderate, unless it's an association from the start. Would it cause any decreased cardiac output or left pressure or any organ ischemia? because of limitation of cardiac output? No, because there is no limitation of cardiac output, and the pressure is actually still maintained. If we go on the area above, we will have now mild to moderate left atrial enlargement, because the pressure now, the mean is 20, with possibility of atrial arrhythmia if it was left for a long time. That means at least months to years, not weeks, not days. Plus, would this give us stagnation of the blood in the left atrium to the extent that we might expect thrombus or clot formation? No, unless chronic atrial arrhythmia, especially atrial flutter fibrillation, is there, then clots can form in the left atrium with its all pathophysiological complications. We will have moderate elevation of the pressure in the pulmonary veins. This will give us at least mild, maybe mild to moderate. Actually, it will not give us moderate. It is just going to give us mild pulmonary venous congestion apparent on the X-ray, and it's usually bilateral. The pulmonary pressure will be moderately elevated, not much permanent or acute or chronic effect on the pulmonary arteriolar bed, unless again it was left for a very long time, because it's still pulmonary hypertension, although it hasn't reached severe pulmonary hypertension. The right ventricular pressure, because it's moderately elevated, we will have right ventricular mild to moderate hypertrophy. The systolic function of the right ventricle is usually maintained. The diastolic function of the right ventricle is usually maintained, unless in extremely long periods where it is left for a long time, they might show affection, but the usual rule in moderate mitral stenosis that the right side, although moderately elevated pressure, will maintain good function and good diastolic filling pressures. Pulmonary valve regurg, probably trivial to mild, not much effect on the pulmonary valve. Tricuspid valve regurgitation may be mild, may reach up to moderate depending on the right ventricular hypertrophy that happens and the function, which is usually quite maintained. So tricuspid regurg, again, here is not a major player in the pathophysiology of moderate mitral valve stenosis, nor would we expect higher pressure in the right atrium, nor in the venous system, and no venous stagnation. And as I said, the cardiac output would be quite maintained. If we go to severe mitral valve stenosis, then the story is different, and I'm sure you already can figure out from what I have just said for the other examples and the other diseases, you can figure out what to expect. So here we expect a mean of above 12 millimeter mercury to call this mitral stenosis quite severe. So when it's quite severe, then there is significant limitation of right-sided cardiac output through the pulmonary veins to the left atrium to reach the left ventricle. So let's talk about, as we said, what would we expect on the left ventricle? End-diastolic volume will be decreased? Possibly, yes. Size, obviously, possibly, yes, decreased. It can range from normal to severely hypoplastic. There's no real guessing or explanation of why does it go from mild, moderate, or severe hypoplasia of the right ventricle or just normal. But in general, the left end-diastolic volume of the left ventricle is decreased in severe mitral valve stenosis. Is the cardiac output maintained? Yes, unless it becomes critical. And why is the cardiac output maintained? Because of so many other regulatory mechanisms that actually maintains the cardiac output, whether it's the elevation of the RV pressure, the hypertrophy, elevation of the pulmonary artery pressure to keep pushing the blood through the stenosis of the mitral valve, and the systemic vascular resistance, which can increase because of it is seeing low cardiac output. It will just tend to vasoconstrict, especially the areas where the blood flow is not needed, like your splanchnic area, and then the blood pressure will be maintained, plus your fight and flight hormone changes that can maintain your cardiac output, given though it is still in the severe area. If mitral stenosis become critical, then we start seeing the low cardiac output state with all its complications of decreased cardiac output, low blood pressure, peripheral and organ low perfusion, ischemia symptoms, and so on. But this is quite a diastase type of condition. So that's the effect of after. So what is the effect of before the severe or critical mitral valve stenosis? We will see significant left atrial dilatation. Sometimes we call it ballooned left atrium. It's huge. It almost is the size of half of the heart or 2/3 of the heart. That's quite a dilated left atrium. So we expect all the complications and the pathophysiology that comes from a dilated atrium. Two major ones. Atrial arrhythmias is quite common in the severe mitral stenosis group, especially if there is a long-term severe stenosis, so atrial flutter, fibrillation, other atrial arrhythmias, variable degrees of heart block, left atrial thrombus formation, especially in the left atrial appendage, especially if it was associated with the arrhythmia, then yes, we would get that effect. We will have significant pulmonary vein enlargement and dilatation with elevation of pressure. So if it is here 12 and if it is above 12, let's say 12 to 18, and if we take the 18 plus the previous 8 of the normal left atrium, then this pressure will be 26. Your pulmonary artery pressure, if the gradient is 18, the difference is 18 plus the normal 18, our mean PAP will be in the range of 35 to 45 millimeter mercury. Now we're heading into the severe area, because if we just add the 20 millimeter mercury to give a systolic pressure, we will have an RV systolic pressure of much more than 55 to 60. At least we will have an RV systolic pressure of around 65 to 75 millimeter mercury. So if this is the situation, I'm sure you now can figure out what's going to happen. We've reached the pulmonary veins. It's quite dilated. The basement membrane pores are now quite stretched. The intravascular fluid proteins will now extravasate into the interstitium of the lung, causing pulmonary interstitial venous edema. The pressure in the venules is extremely high. It will cause reflex bilateral pulmonary arteriolar vasoconstriction, leading to the severe pulmonary artery pressure elevation. Pulmonary artery pressure complications is part of the pathophysiology of severe to critical mitral valve stenosis. It may give you long-term effects in terms of permanent, chronic on the pulmonary arteriolar bed if left untreated for a long time. Usually it's much less aggressive than primary pulmonary hypertension, but again, it is severe pulmonary artery pressure with all the package that comes with it. The pulmonary arteries will also, the main pulmonary arteries will be significantly dilated and their walls will be thickened. The muscular part of the pulmonary artery wall will be quite significantly hypertrophied, and the fibrous part will quite be thickened and stiff. We may have, or we will have, when we have severe pulmonary pressure elevation, we will have significant mild, maybe mild to moderate pulmonary regurgitation, although it will not be a major player in the whole pathophysiological effect. The right ventricle will significantly hypertrophy. It may dilate, it may lose systolic function. The left ventricular, the right ventricular end-diastolic pressure will elevate, and then we will have varying degrees of tricuspid valve regurgitation depending on how much annular dilatation because of right ventricular dilatation and hypertrophy. We may have mild, moderate to severe, and hence we do expect an elevation of the right-sided venous pressures, the right atrial pressure, the superior vena cava and the inferior vena cava, with all the effect on other venous systems, whether they are upper body and brain, or it is lower body, the liver and the splanchnic area, with all the pathophysiological effect of elevation of a venous pressure systemic. All of that can give us significant pathophysiological effect. So you see, severe mitral stenosis, and especially if it was more towards critical, has a very bad effect on all the components. Left-sided cardiac output, left-sided ventricle, left atrium, the pulmonary veins, the pulmonary artery, pressure and structure, the pulmonary valve regurg, the right ventricular loss of function, elevation of pressure, loss of function, hypertrophy, dilatation if left, and dysfunction if left for a long time, tricuspid valve regurgitation as a complication, pathophysiological finding because of severe or critical mitral stenosis, and right-sided congestion with all its back effect on the body, and even right-sided venous thrombus formation in the worst situation. By this, I hope I have covered up to mitral valve stenosis pathophysiology. In the next sessions, inshallah, I will cover the aortic valve stenosis, coarctation of the aorta, to end up the pathophysiology of left-sided obstructive lesions. And from there, inshallah, we will move into regurgitant lesions, pathophysiology. Hopefully, I can also do the pathophysiology of acquired heart disease in children, especially rheumatic heart disease and Kawasaki. Thank you so much.